Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Today's webinar, Treatment of Functional Pituitary Adenomas at a Pituitary Center of Excellence, a Multidisciplinary Approach, presented by Dr. Zenonos and Dr. Fazeli of UPMC. Please hold as there will be a brief delay while we change presenters.
All right, excellent.
Perfect. All right, you're all set. Thank you.
Excellent. Well, thank you so much again for the opportunity. I'm Giorgio Zenonos. I'm one of the skull-base neurosurgeons at the University of Pittsburgh, specializing in both skull-base and pituitary disorders. It's a great pleasure to be joined by Dr. Fazeli, who is our chief for neuroendocrinology unit and professor of medicine here at UPMC. It's always exciting to be part of this PNA series, as I think it's a fantastic forum where patients can receive credible information, and it's a also nice opportunity for physicians to share their both their expertise, their experience, and their perspectives on different matters. So it's always a great pleasure. And today's topic will be the treatment of functional pituitary adenomas at a Pituitary Center of Excellence, a multidisciplinary approach. So these are our disclosures. None of them are really relevant for today's webinar. And our goals for today are to describe a Pituitary Center of Excellence, as well as its importance in the treatment of functional pituitary adenomas. For those that are not familiar with the term, of course, functional pituitary adenomas are the ones that are producing hormones, and those are associated with specific challenges in their management. And some of our goals today is also to describe some of the advancements in the diagnosis or treatment of these diseases. So what is a Pituitary Center of Excellence? It's a sort of an obscure term, but it is a specialized center. And the sine qua non of this center is a multidisciplinary team that specializes in the treatment of pituitary disorders. There's a lot of practitioners, neurosurgeons, neuroradiologists, neuroendocrinologists, etc. that we'll go over, that all work harmoniously as a team to treat the disorders. It has to have a high volume, so experience matters. And baked into the definition of a Pituitary Center of Excellence is to have a certain volume, which the very least is to have like about 50 cases a year. Ideally, it should be hundreds a year. Even more importantly, is actually having benchmarks and tracking of outcomes. So both positive outcomes, such as degrees of resections, the endocrinologic remissions, but also negative outcomes, the complications, they have to be kept under a certain rate. For example, infections, cerebrospinal fluid leaks, and so on, readmission rates, and so on and so forth. And the last piece, but also, again, very important, is the research mission. So these centers are usually the thought leaders, and they're comprised of people that have devoted their careers and the whole research mission into advancing the field and bettering the treatment of patients with pituitary disease. So a pituitary sometimes can be thought of as a simple disorder, a simple tumor, but not all pituitaries are the same. And there are some of pituitaries that can be quite challenging to treat. And this is when they escape the confines of the pituitary, and they really need scalp-based expertise in order to be treated appropriately. This is even more true for functional pituitary adenomas. And the multidisciplinary approach really shines here because the first step is actually identifying whether this is a problem. We have the big three: Cushing's disease, acromegaly, prolactinomas, and also some more obscure tumors. But actually localizing where the problem is and identifying the disease process is step number one, and really perhaps one of the most important steps. So surgery is the first step for Cushing's disease and acromegaly, whereas for prolactinomas, usually medical therapy. And it comes into play for prolactinomas when that fails. But surgery is even more important to be done appropriately for these tumors, as every last little cell has to be removed for the patient to go in remission. Otherwise, the patients are tethered to lifelong medical treatment, radiation therapy, and really, the goal here is ideally is to separate the patient from the disease and not have them have a chronic disease process, which has many repercussions down the line. We're lucky at the UPMC to have a fantastic team of neurosurgeons, otolaryngologists, neuroendocrinologists, neuro-ophthalmologists, oculoplastic surgeons, radiation oncologists, neuroradiologists, neuro-oncologists, neurophysiologists, and neuroendovascular specialists. And truth be told, all of these people have to work harmoniously to make everything work appropriately. And if in one part of this whole machine is malfunctioning or is not communicating well with the rest of the practitioners here, the whole thing falls apart and the patient pays the price. So it's very important not for these components to exist, but to work together harmoniously in a way that benefits the patient. At UPMC, we've had a rich history in scalp-based surgery with the first comprehensive scalp-based center introduced here. And it's also credited with the introduction of endoscopic pituitary surgery, with the first one being performed here. And really, the introduction of the endoscope, which is essentially a camera at the end of a long stick, essentially, has really revolutionized the way that we can do pituitary surgery, as we can see a lot more and be a lot more accurate on how we do things. On the right here, we see an example of endoscopic surgery compared to the microscopic, which is a traditional way to do this. Most centers, I would say, have adopted the newer techniques on the right. Again, you can see very clearly how you can see a lot more. Working together with ENT surgeons, where they driving our visualization in a dynamic manner and allow us to see more and be more effective and safe in what we do. But of course, that is just a tool. We have to know the anatomy and the surgical technique and modules in order to be able to access everything. Again, teamwork is the name of the game, and has allowed us to revolutionize a lot of the techniques over time in order to be able to access everything that we need to access to deal even with the most complicated of pituitary disease, which is essentially scalp-based surgery and not just the pituitary. One of our latest advancements, again, part of our mission is to advance the field, is the use of spatial computing in performing pituitary surgery. We performed the first mixed reality case here at UPMC, and we've now increased our experience by several patients, where we have a lot more situational awareness, having all the information in front of us using mixed reality platforms and spatial computing. Surgical techniques have been always the key stone to good surgery, and the access into this area around the pituitary gland, the so-called cavernous sinus, has always been a limitation. And that has been areas where a tumor was left behind and tear the patients again to lifelong medical treatments and radiation therapy. That's because there's a lot of important things there, such as the nerves that move the eyes, that allow us to feel the eyes, our face, and also the carotid artery, which is a very important artery, so it's coined as no man's land. And again, this narrow exposures, this incomplete resections had repercussions down the road, creating like a chronic disease where in fact this is a disease that sometimes can be very effectively cured. These membranes around the pituitary gland have really changed the way that we think about functional pituitary adenomas, because those are areas where these cells that are producing the hormones can hide, and they can come back even after an apparent initial remission. These have been very accurately described now, and again, up to 83% of functional pituitary adenomas will have cells that infiltrate these membranes, and removal of these membranes with more advanced techniques has really advanced our ability to be more effective and put patients in remission when we do surgery for functional pituitary adenomas. One such example is this patient with Cushing's disease that was operated on initially with a microscopic approach by a very experienced surgeon, went into remission, but 5 years later had this recurrence exactly into these membranes, what we call the medial wall of the cavernous sinus. That's the inner side of that membrane that contains all the nerves. And there, again, techniques that were described initially here at UPMC that allow us to remove these components. As you see here, we have the normal pituitary gland and the tumor. And after we remove the tumor carefully, there's still this remnant into these membranes around, into this medial wall of the cavernous sinus. That's usually an area where the tumor can come back. So being comfortable managing the nerves around this area in the cavernous sinus, the carotid artery, and being able to mobilize these membranes in order to remove them appropriately has really increased significantly our effectiveness in terms of treating this disease. Here's our patient again with a recurrence, and I do want to show a video of the actual surgery, because I do believe if a picture is 1,000 words, a video is actually 1,000,000 words, as it really shows what actually happens. This is nicely annotated here. This is one of my ENT partners that has the camera and really shows us what we need to see. This is a pituitary gland and that very important artery, the carotid artery. The bone has grown back here, and we really expose that artery here in order to be able to access this area that's the medial wall of the cavernous sinus where the tumor has grown back. There's some components of the bone here that we have to adequately manage. You have to be very careful with the technique and where you remove this bone, but this is very safely done in appropriate technique and hands. And once we have our nice exposure here and everything laid down in front of us, then we can go ahead and start removing the tumor. I'm going to move this forward a little bit, but you see here the area where the normal gland is, and that's the area of the membranes where this tumor has grown back. It's very normal to have a little bit of back bleeding from this area, as it normally involves blood, and it's like a large vein that we have to open into. So it's very normal to open into this, or there's more hemostatic materials. We're able to stop the bleeding here and actually work comfortably into that area. We do have to be careful again with the nerves, and we use advanced neurophysiology. This actually is an electrified instrument where if we get close to one of those nerves, this is the abducens nerve that we're trying to find here. They will notify us, our neurophysiologists would notify us, and we manage those membranes, mobilize them. This is one of the ligaments, which is one of the thickened membranes around it that we have to disconnect. And again, this is a very sort of delicate surgery in order to be able to mobilize this safely around the area of the carotid artery and the cranial nerves. But this is exactly where the problem is. And that's, if we don't remove that, the patient is not going to go in remission. They require radiation therapy. If you radiate this area here, some of the radiation will go to the pituitary gland, and that may mean that the patient will have to take replacement medication afterwards because the pituitary gland was hurt. So the best case scenario is really to be able to remove these cells that are producing the hormones. And here nicely, we're very comprehensively removing every last little part of the membranes that was attached to the tumor, and that's all you need to do. And then we replace the lining here with what we call a nasal flap, and the patient did quite well. Here you see the postoperative scan, not only by removing that little spot, but all the membranes around it, and the patient went into remission. So this again has really revolutionized the way that we treat these tumors. The question is it too risky to do? And the answer is no. In appropriate hands, it can be done very safely. So it is published and published again. Even with the so-called NOS tumors that don't just involve this area right next to the pituitary gland, that go all the way around the carotid artery, we devise these methods where we open in the area to the side of the carotid artery by mobilizing this carotid artery medially towards the center. We're able to access this compartment in a very effective way, so that many of these tumors that were, quote, previously, quote unquote, unresectable, with newer techniques and by experienced teams can be very adequately addressed. So I'm going to turn to my colleague, Dr. Fazeli, and she's going to go over some of the medical aspects of treating these diseases. Fazeli.
So thank you, and it's a pleasure to be here. And I would just like to highlight with Cushing's disease and the case that Dr. Zenonos presented, one of our biggest challenges is recurrent Cushing's. And what was interesting about that patient is I believe I referred her to Dr. Zenonos before she actually had biochemical evidence of her recurrence. And it's important to highlight that patients often know before their physicians that their Cushing's has recurred. And so for us, it can be a big challenge because the patient very knowingly is aware that their Cushing's disease has come back, but there is not yet biochemical evidence. Patients with a history of Cushing's disease should be followed at least yearly for the possibility of recurrence. And typically late night salivary cortisols are often the first biochemical test that is positive in the setting of recurrence. And that is what happened with that patient. And I will say she was in remission for a number of years and was lost to follow-up. And so she presented to us as a new patient. And so it was very interesting to see her come back before she had biochemical evidence of her recurrence. So now moving on to the second patient that we'll present today. This was a 29-year-old woman who had regular menstrual cycles until she was 26 years old, so until 3 years before she presented, and then she developed amenorrhea, or a complete loss of her menstrual cycles. She also had developed galactorrhea, or lactation, breast milk production, in the 3 years prior, and reported a history of headaches that worsened over the last year. She had an appropriate evaluation by gynecology, and the first test they did was they excluded the possibility of pregnancy, which is the most common cause of loss of menstrual periods. She also had thyroid function tests, which were checked and were normal. And they measured a prolactin level, and her prolactin level was very high. It was 1,000 nanograms per milliliter, and normal is less than 20 nanograms per milliliter. And prolactin is a hormone that is made by the pituitary gland. So when we think about causes of hyperprolactinemia, there are a number of causes. There are physiologic causes of hyperprolactinemia. So prolactin levels increase during pregnancy. They increase in patients or in individuals who are nursing. And the range of prolactin levels, for instance, right before a patient delivers, can be as high as 600 nanograms per milliliter. There are also medication-induced causes of hyperprolactinemia. They can range from antipsychotic medications, which are dopamine antagonists, and prolactin levels can be quite high in patients who are on antipsychotic medications, and they can be as high as 300, even 400 nanograms per milliliter. Again, normal is less than 20. And then there are pathophysiologic causes of hyperprolactinemia. And the range of prolactin levels, again, can be anywhere from low levels to levels as high as in the thousands. And when we see a prolactin level in the thousands, there's really one primary diagnosis that we think about, and that is a prolactinoma. There are very few causes of prolactin level in the 1,000 nanogram per milliliter range. And as you'll remember, our patient had a prolactin level of 1,000 nanograms per milliliter. So very appropriately, she next had a pituitary MRI. So the pituitary MRI that I'm showing right now is an individual with a normal pituitary gland. You can see that the pituitary gland is a rectangular shaped object between the two carotid arteries. You can see the stalk that connects the pituitary gland to the hypothalamus, and you can see that the optic chiasm, which supplies peripheral vision or side vision, lies right above the stalk connecting the pituitary gland to the hypothalamus. So this is a coronal post-contrast T1 weighted image. So the patient is looking out at us with their face removed. And here you can see our patient's pituitary MRI. So you can see that instead of having a rectangular shaped pituitary gland, she has a 14 millimeter hypoenhancing or dark lesion that is in the space where the pituitary is. And you can see that it's moving up towards the optic chiasm. So this is likely the cause of her elevated prolactin levels. So she has what we call a prolactinoma or a lactotroph cell adenoma. So what are the clinical effects of hyperprolactinemia? So this was a study of women presenting to an infertility clinic. This was a study of 100 women, and perhaps not surprisingly, the most common reported symptom was infertility. So nearly 50% of women with hyperprolactinemia presented with infertility. 40% presented with headaches, 30% had irregular menstrual periods or oligomenorrhea, 25% reported galactorrhea or lactation, and 15% of these women reported visual changes. So there was also a study of 22 men who presented with hyperprolactinemia, and far and away the most common symptom reported was erectile dysfunction, with nearly 90% of the men reporting erectile dysfunction. 40% reported visual changes, 30% reported headaches, and slightly under 20% reported lactation or galactorrhea. So how do we treat prolactinomas? So Dr. Zenonos already mentioned that for Cushing's and acromegaly, first-line treatment is typically surgery. For prolactinomas, medical therapy is first-line treatment. And patients who have microadenomas, so those are pituitary lesions that are less than 1 centimeter in size, can potentially be followed without treatment with serial prolactin levels and MRI imaging, as long as they're asymptomatic and as long as their MRI remains stable. And so therefore, I think it's important to note that we don't necessarily always have to treat a number. There are patients who have high prolactin levels who are completely asymptomatic. They continue to have regular menstrual cycles. The females have regular menstrual cycles. They're not having lactation. And so we don't need to treat that elevated number as long as the pituitary imaging stays stable and as long as they remain asymptomatic. So in terms of how we treat prolactinomas and how medical therapy works, it's important to remember and to understand normal pituitary and prolactin physiology. So the hypothalamus sits above the pituitary gland and is connected to the pituitary gland by a stalk, and the hypothalamus secretes dopamine through the stalk, which then attaches to the D2 receptors on the lactotroph or the prolactin producing cells. And there is inhibition of prolactin secretion by dopamine. So that keeps the prolactin levels in check. So when we're treating prolactinomas, we use dopamine agonists, so medications that attach to those D2 receptors to treat the prolactinoma. And dopamine agonist therapy can normalize the prolactin levels and can also reduce and often shrink away the adenoma, or at least stabilize the size of the adenoma. And in the US, we have 2 dopamine agonist treatments. We have bromocriptine, which is used daily, and we have cabergoline, which is a weekly or biweekly dosed medication. Now, again, we don't necessarily have to treat the lactotroph cell adenoma. We can treat the symptoms as long as the lesion is not growing. And we can do that with hormone replacement therapy. So we don't necessarily need to treat the number if the prolactinoma is not growing. We can treat the symptoms of loss of menstrual periods or low testosterone level with hormone replacement therapy. And this is typically something we would use in individuals who are not interested in pregnancy or in conceiving. And dopamine agonist therapy is very effective at shrinking the tumor and normalizing prolactin levels. So this is a patient on the left. You can see a presentation. You can see that on the left side, there is a hypoenhancing or darker lesion that is within the sella and within the pituitary space. And the prolactin level at presentation was 354 nanograms per milliliter, again, normal being less than 20. And you can see after 1 year of treatment with cabergoline, which again is a dopamine agonist therapy, the prolactin level normalized. It's now 10 nanograms per milliliter. And you can see that there has been substantial shrinkage of that adenoma. And oftentimes patients can have complete remission of their prolactinoma. And 30% of patients in whom that there is no evidence of adenoma and who have a normal prolactin level can be weaned off dopamine agonist therapy if they've been on the medication for at least 2 years, and they go into remission and don't need treatment again. Now, dopamine agonists don't come without costs, and there are a number of side effects or symptoms that can be associated with dopamine agonist therapy. So the most common, far and away, are gastrointestinal side effects. Patients can have lightheadedness. In patients who are on anti-diabetic medications, they can develop low blood sugar. So oftentimes their anti-diabetic medications can be titrated down. Their doses can be lowered. The most significant side effect that I counsel patients on and that we have noticed and become aware of in the last 10 to 15 years is the increase in psychiatric symptoms or impulsive behaviors. So every patient that is started on a dopamine agonist needs to be counseled on the potential, and it's a rare side effect, but it can be devastating if it can happen, of impulsive behaviors, including gambling or, for instance, uncontrolled spending. And I would say that over the last 10 or 15 years, we have noticed a number of patients who presented with this side effect. And I think it's not because it's happening more commonly, but it's because we're aware of it and we're counseling patients on it and they're reporting the side effect or symptom to us. In patients who are taking cabergoline, there is also a potential risk of heart valve abnormalities. This was noted in 2 studies that were done in patients who were treated with cabergoline for Parkinson's disease. Now, the doses of cabergoline that are used in Parkinson's disease are quite a bit higher than the doses we use to treat prolactinomas or pituitary disease. So the average median weekly dose in patients who are treated for Parkinson's disease is about 21 milligrams per week. And a typical dose for patients who are treated with prolactinomas is 1 or 2 milligrams per week of cabergoline. So you can see that there's a vast difference in the typical dose of cabergoline that we use to treat patients with prolactinomas. Patients with Parkinson's also tend to be older than patients with prolactinomas, and there have been a number of studies that have looked at, retrospective studies that have looked at whether there's an uptick in heart valve abnormalities in patients who are treated for prolactinomas with cabergoline. And the vast majority of the studies don't show evidence of that, but there are a number of case reports, a few case reports, and it seems to be that in patients who are on very high doses of cabergoline for long periods of time, there are case reports of heart valve abnormalities reported in patients treated for pituitary disease. Now, in terms of follow-up for our patient, so we started her on low-dose cabergoline. We started her on half a tablet or 0.25 milligrams of cabergoline twice per week. And we repeated a prolactin level after 1 month, and it remained elevated. So what we would have typically done is we would have increased her dose of cabergoline and then again followed her prolactin level and repeated it a month later and titrated the dose. But when I called her to talk to her about her prolactin level and the potential need to increase the dose of cabergoline, she reported symptoms of increased spending and online gambling. And so that became a very worrisome potential symptom of treatment with cabergoline. So do we use surgery? And Dr. Zenonos has published on this, and surgery is now more and more commonly used to treat prolactinomas. And who do we treat surgically? So we treat patients like our patient who's unable to tolerate medical therapy, potentially due to side effects and symptoms. We also treat patients who have contraindications to treatment with cabergoline and require treatment. So patients potentially with psychiatric disease who are on antipsychotic medications, which are the opposite of dopamine agonists. They are dopamine antagonists. And so it would be potentially contraindicated to treat those patients with dopamine agonist therapy. Patients who have visual field defects or abnormalities that are unresponsive to medical therapy should be treated surgically. And patients with adenomas who have growth, which is unresponsive to medical therapy, should also be considered for surgery. And then we also think about surgery in women who have a stable but large tumor, who are interested in conceiving and don't have time to potentially wait for medical therapy to take effect. And that's because the risk of clinically significant growth during pregnancy, while it's very low for a microadenoma, so again, an adenoma that is less than 1 centimeter in size, it's actually quite high for patients with a macroadenoma, so adenomas that are greater 1 centimeter in size. The risk of clinically significant growth during pregnancy is greater than 20%. And that's because prolactinomas are estrogen responsive, and estradiol levels are quite elevated during pregnancy due to secretion from the placenta. So in those patients, we potentially want to treat them surgically before they get pregnant so that we don't risk their pituitary tumor growing during pregnancy and causing visual field defects. So for this patient who had side effects and symptoms in response to medical therapy, we referred her for surgery, and she was successfully treated surgically for her prolactinoma. So our next patient is a 24-year-old woman who presented with a 1-year history of amenorrhea, again, losing her menstrual period or menstrual cycles after she stopped taking oral contraceptive pills or birth control pills. She was again evaluated by her primary care physician. She was not pregnant, had normal thyroid function tests, and she had a prolactin level measured, which was very appropriate. And it was found to be mildly elevated at 35 nanograms per milliliter. So you'll remember our other patient had a very elevated prolactin level of nearly 1,000. This patient's level was mildly elevated. And whenever we see a patient who has a mildly elevated prolactin level, the first thing we do is we repeat an early morning fasting prolactin level. And that's because things like food and stress and activity can cause a rise in prolactin levels. And so she had an early morning fasting prolactin level repeated, and it was still mildly elevated at 32 nanograms per milliliter. Her review of symptoms, she reported that she was having headaches for the last 6 months, and she had also reported the development of new acne. So she was told to restart her oral contraceptive pills. Her primary care doctor thought the prolactin level is only minimally elevated. So if anything, this is just a small prolactinoma. And perhaps the new acne is a sign of polycystic ovary syndrome. It's now referred to as polyendocrine metabolic ovarian syndrome. Very recently, the name has been changed. So, you know, there was a thought that there was a reason for her lack of menstrual periods and her new acne. 2 months later, she continued to have headaches and developed significant vision changes, and she saw her ophthalmologist, her eye doctor, who noted bitemporal hemianopsia, or loss of her peripheral vision, on visual field evaluation. And here you can see these dark areas are where she lost her vision in her visual field. So she had a pituitary MRI. Again, on the left-hand side is a normal post-contrast coronal image, which again is the patient looking out at us with their face removed. And on the right, you can see our patient's pituitary MRI, you can see there's a 2.5, 3 centimeter lesion that is pushing the optic chiasm upwards and has caused her to lose her peripheral vision. And again, her prolactin level is only minimally elevated. So why is her prolactin level high? And again, when we think about why her prolactin level is high, she clearly doesn't have a prolactinoma because her prolactin level is only 35, but she has this large lesion. We have to think about the normal physiology, normal prolactin physiology. Again, the hypothalamus secretes dopamine through the stalk, which attaches to the D2 receptors or the dopamine receptors on the lactotroph cells and causes prolactin levels to remain normal. So if there's any disruption of the stalk, if there's a large lesion that is not a prolactinoma, but is disrupting the flow of dopamine from the hypothalamus to the pituitary gland, that will cause an elevation in prolactin levels because the dopamine can't get to the pituitary gland. So this patient had what we call stalk effect hyperprolactinemia. So she doesn't have a prolactinoma, but she has a large lesion that is interfering with the ability of dopamine to get to the pituitary gland. So whenever we have a patient with a pituitary macroadenoma, so a lesion that is greater than or equal to 1 centimeter in size, we always screen for both pituitary hormone deficiencies. So anything greater than 1 centimeter we think of as having the potential for causing loss of pituitary hormone function. And we also screen for pituitary hormone excess. So we already know her prolactin level is mildly elevated. She had normal thyroid function tests. We screen for adrenal insufficiency and also cortisol excess, gonadal axis assessment. So she has loss of menstrual periods. So we know that this is interfering with her pituitary hormone function and the ability of the pituitary to signal the ovaries for her to have a normal menstrual cycle. And we also check for growth hormone excess, which growth hormone is a pituitary hormone, and it stimulates the liver to secrete IGF-1. So whenever we're screening for growth hormone excess, we measure an IGF-1 level. And this patient's IGF-1 level was elevated at 775 nanograms per milliliter, with normal being up to 456 nanograms per milliliter. So she has what we call a growth hormone secreting adenoma or acromegaly. So the prevalence of acromegaly is estimated to be about 30 to 70 per million individuals, but we think this is probably a gross underestimate because screening studies in unselected individuals suggest that the prevalence can be as high as 1,000 per million. At the time of presentation, 75% of patients with acromegaly have a macroadenoma, so they have a pituitary lesion that is greater than or equal to 1 centimeter. And the mean time to diagnosis is often over a decade. So patients live with acromegaly for many, many years before it's diagnosed. And that is probably for 2 reasons. One, growth hormone is a growth promoting factor, so it can lead to potentially larger lesions, but also because the symptoms of acromegaly are very non-specific. And so unless a physician is asking the right questions, it can be easily missed and overlooked. How do we make the diagnosis of acromegaly? So an elevated IGF-1 level in patients who have clinical signs and symptoms of acromegaly is enough for diagnosis, but we can also use an oral glucose tolerance test. And in individuals who have an oral glucose tolerance test, if their nadir or lowest growth hormone level is greater than 1 nanogram per milliliter, that is diagnostic of acromegaly. So there are a number of diagnostic challenges with acromegaly because there is the potential for a falsely normal IGF-1 level or potentially falsely elevated growth hormone level. So we see growth hormone resistance in states of undernutrition. So for instance, women with anorexia nervosa have growth hormone resistance. So they might have a falsely normal IGF-1 level, even if they have a growth hormone secreting adenoma. We also see that in individuals with protein deficiency and also patients who are on oral contraceptive pills. So oral estrogen can block growth hormone signaling, so it can potentially block growth hormone's ability to signal the liver to produce IGF-1, and it can cause a falsely lower or falsely normal, potentially IGF-1 level. So these are all things that we think about when we're diagnosing a patient with acromegaly. There are a number of signs and symptoms of growth hormone excess. So patients may report an increase in shoe size, an increase in hand size, enlarged tongue. They might have snoring or obstructive sleep apnea. So there are a number of signs and symptoms, and many of them are nonspecific. For instance, a lot of people have hypertension or high blood pressure and don't have acromegaly. A lot of people have insulin resistance and diabetes and don't have acromegaly. So these are potentially there are specific signs and symptoms, for example, an increase in shoe or hand size, but then there are also less specific signs and symptoms like high blood pressure and diabetes. The one I'd like to highlight is polycystic ovary syndrome, like our patient who presented with irregular menstrual periods and acne, also now known as polyendocrine metabolic ovarian syndrome. And the reason I'm highlighting this is because we did a study and looked at patients with acromegaly who were diagnosed with polycystic ovary syndrome or who met criteria for polycystic ovarian syndrome and compared them to those who did not have or who did not meet the criteria for polycystic ovary syndrome. And we found that those who met the criteria had a longer time to diagnosis than those who did not meet the criteria. So the median time to diagnosis in patients who met the criteria for polycystic ovary syndrome from the onset of their symptoms was 5 years compared to 2 years in those who did not meet the criteria. And that was because they were being diagnosed with polycystic ovary syndrome and instead of thinking about the potential diagnosis of acromegaly. In terms of treatment, again, surgery is recommended as first-line treatment, but we do have a number of medical therapy options now, and those are for patients who potentially are not in remission after surgery. So there are medications that act on the tumor, so these include somatostatin analogs or agonists, and these bind to the somatostatin receptors, which are on the pituitary adenoma or the pituitary tumor. We have a number of options now. We have injectable monthly formulations. We have a twice-a-day oral medication, and now more recently we have a once-a-day oral medication that can be used to treat acromegaly. Dopamine agonists can also be used in specific patients with acromegaly, particularly those who don't have a very high IGF-1 level post-surgery. We also have a growth hormone receptor blocker, which acts peripherally to block growth hormone action. So this will not treat the tumor. If you measure growth hormone level, it will be very high in patients who are on a growth hormone receptor blocker, but IGF-1 levels will normalize on a growth hormone receptor blocker. So for our patient, she underwent surgical resection, and you'll remember she had a 2.5 to 3 centimeter lesion preoperatively with an elevated IGF-1 level of 775 nanograms per milliliter. And post-op, you can see she had both radiologic remission, and she also had normalization of her IGF-1 level. It was now 217 nanograms per milliliter, but this is someone we will continually follow for potential recurrence. Every patient with Cushing's, every patient with acromegaly, patients with prolactinomas, we continually follow them even if they're in remission for the possibility of recurrence. So in conclusion, functional pituitary adenomas are complex disease processes which pose challenges in accurate diagnosis and treatment. Pituitary centers of excellence provide multidisciplinary care, which is paramount for the appropriate management of functional pituitary adenomas. And advancements in diagnostic and surgical techniques, as well as medical management, are significantly improving outcomes. So we'd like to thank you for allowing us to present today, and we'd be happy to take any questions.
Thank you so much for another wonderful presentation. We really appreciate it. We do have a couple questions here, and feel free to send in more, everybody. Our first question is, how often is follow-up for those in remission?
So we typically follow patients yearly, but every time I see a patient and we do the screening laboratory work, I tell them that if there's going to be a recurrence, it will not fall on my calendar or go by your calendar. So if you have any signs and symptoms in the interim, again, patients who have recurrent Cushing's disease oftentimes know before the biochemical testing shows that their Cushing's is back. So although I see a patient yearly when they're in remission, we always do keep in communication in the interim in case they develop any signs or symptoms.
Okay, thank you. And that was actually our only question. I thought we had a couple more, but that was all we have today. So this will conclude our webinar presentation. We appreciate you all taking the time to join us. If you missed any part of this webinar or you'd like to share it with family or friends, it will be available on our website at www.pituitary.org. There will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need. Thank you again for joining us, and enjoy the rest of your day.
Thank you.
Thank you.
Thank you both.